Hello and welcome. My name is Dr. Hannah Rosa. I'm a GP working in the northeast of England and a member of the GPnotebook education team. In 2024, the British Thoracic Society, NICE and SIGN joined together with the aim of improving the lives of people living with asthma. And in November last year, they published their joint guideline on asthma diagnosis, monitoring and chronic management. Want to find out what's changed? Well, I'll be going through the guideline in detail over 2 podcasts. In part 1, which was released on the 6th of March, we covered diagnosing asthma and the pharmacological management in people aged 12 and over. In part 2 today, we will cover pharmacological treatment in children aged 11 and under, monitoring asthma control, and self-management. At the end of this podcast, I also have a quick quiz for you. I'd just like to start now with a reminder of 4 general principles, which will apply throughout this podcast, but to save myself repeating them and you from getting sick of hearing them, I thought that I'd get them out the way first. Number 1, for all patients with asthma, we should review their response to treatment 8 to 12 weeks after starting or adjusting any medication. Number 2, that uncontrolled asthma refers to any exacerbation requiring oral corticosteroids or frequent regular symptoms such as using a reliever inhaler 3 or more days a week or nighttime waking 1 or more times a week. Number 3, when seeing a patient with uncontrolled asthma, before starting or adjusting medication, we should try to address any possible reasons that might be causing it. For example, review the diagnosis. Has asthma been diagnosed with an objective test? Or is an alternative diagnosis more likely? Are there any comorbidities which may be making the asthma worse? Check adherence and inhaler technique. Screen for active or passive smoking, including e-cigarettes, and other environmental factors, such as air pollution and indoor mould exposure. And number 4, if possible, check the FeNO level when asthma is uncontrolled. If it is raised, this may indicate poor adherence to treatment or the need for an increased dose of an inhaled corticosteroid. Let's now focus on pharmacological management for children aged 5 to 11. If, for example, you are reviewing a 7-year-old child with a new diagnosis of asthma, what pharmacological management is recommended as step 1 in the new guideline? Is it a SABA inhaler, PRN alone, a SABA inhaler and a regular steroid inhaler, or a combination inhaler to be used as air or anti-inflammatory reliever therapy? Well, in the previous 2017 NICE asthma guideline, a SABA inhaler alone was an option. And now, for people aged 12 years and over, air therapy with a low-dose steroid and formoterol combination inhaler is the first-line option. However, for our patients aged 5 to 11 years, step 1 is a twice-daily pediatric low-dose inhaled corticosteroid with PRN SABA. Regular low-dose ICS plus SABA has been shown to be superior to SABA alone, particularly in reducing exacerbations. So just to highlight that these patients, and in fact all patients with newly diagnosed asthma, should now never be prescribed a SABA inhaler alone. If, when reviewing this child, they still have uncontrolled asthma, then we should assess the child's ability to manage a MART regime. Now, as the MART regime only involves using 1 inhaler for both regular treatment and symptomatic relief, For most, this is going to be the easiest path to follow. So who is the guideline referring to when they suggest that some children won't be able to manage a MART regime? Well, my first thought here was for those children who don't want to give up their SABA inhalers, as they know that they work well for them. The guideline, though, highlights that the current evidence supporting the use of MART in children under 12 is based on the use of dry powder inhalers. And they state that some children might struggle to use a dry powder inhaler, particularly when breathless. However, in my experience, most children, even when breathless, can still manage to take a dry powder inhaler. In fact, because a dry powder inhaler requires a quick and deep breath in, and this is the type of breathing that a breathless person usually does, dry powder MART inhalers may actually be easier than metered dose inhalers and spacers, which ideally require a slow and steady breath in. So, if going down the MART route, we should stop the ICS and SABA inhalers and switch to a paediatric low-dose MART inhaler. If the child still has uncontrolled asthma on a paediatric low-dose MART, then the next step is to consider increasing to a paediatric moderate-dose MART. And if the asthma is still uncontrolled on this, the final step is to refer the child to a specialist in asthma care. The guideline highlights that, at the time of publishing, no asthma inhalers were licensed for MART in children under 12, so their use is off-label. So what about the other pathway we can go down for the children who can't manage a MART regime and they have uncontrolled asthma on a twice-a-day low-dose inhaled corticosteroid? Well, these children should keep their SABA inhaler and follow the following maintenance therapy steps. The first is to consider adding to the twice-daily paediatric low-dose ICS a leukotriene receptor antagonist, such as montelukast, for a trial period of 8 to 12 weeks, and then stopping it if it has been ineffective or if it has caused side effects. The guideline reminds us that in 2024, the MHRA published a drug safety update on montelukast, alerting us that we should be aware of the risk of neuropsychiatric reactions, including sleep disorders, hallucinations, anxiety and depression, as well as changes in behaviour and mood. The next step, if asthma is still uncontrolled, is to switch the ICS inhaler to a twice-daily paediatric low-dose combination inhaler containing a corticosteroid and a long-acting beta-2 agonist, with or without the leukotriene receptor antagonist. If asthma remains uncontrolled on this, then we should offer a twice-daily paediatric moderate-dose combination inhaler containing an ICS and LABA, again with or without the leukotriene receptor antagonist. The final step, if asthma is still uncontrolled, is to refer to a specialist in asthma care. Now, you may be thinking that these pathways are all very good, but when seeing a child in primary care, what do I actually prescribe and at what dose? Well, fear not, as there is a very good resource produced by NHS Dumfries and Galloway, which guides you through the new asthma guideline and lists the actual inhalers and doses which are suitable for each step. For example, the MART dry powder inhalers that they advise are Fobumix 80/4.5 and Symbicort 100/6, with 1 puff BD being a maintenance paediatric low dose and 2 puffs BD being a maintenance paediatric moderate dose. I've put a link to this resource in the show notes. So that's our management of asthma for the 5 to 11-year-olds covered. Now let's focus on the under 5s. And here I'd like to begin with a reminder of something that I mentioned in the previous asthma podcast. New in the 2024 guideline is the advice that we should refer to a specialist respiratory paediatrician any preschool child who has had 1 admission to hospital or 2 or more admissions to an emergency department with wheeze in a 12-month period. It's also worth remembering that it's difficult to make a firm diagnosis of asthma in this age group, and that episodes of cough and wheeze can occur with recurrent viral infections and be difficult to distinguish from asthma. For this reason, the guideline is quite specific when it comes to when we should consider maintenance pharmacological therapy for children under 5. They state that we should consider an 8 to 12 week trial with a twice daily paediatric low-dose inhaled corticosteroids alongside a SABA inhaler if we suspect that they have asthma and they have either of the following. Number 1, symptoms that indicate the need for maintenance therapy. For example, they have interval symptoms such as a persistent cough, which is worse at night, alongside another atopic disorder, such as hay fever, eczema, allergic asthma, or other specific and non-specific allergic conditions, such as a food allergy. Or number 2, they have had severe acute episodes of difficulty breathing and wheeze, for example, requiring hospital admission or needing 2 or more courses of oral corticosteroids. So, a 4-year-old with a mild, recurrent but not persistent cough would not qualify for maintenance asthma therapy. You will have noticed then that the first step for under 5s is the same as for the 5 to 11-year-olds, a twice daily paediatric low-dose inhaled steroid inhaler with a SABA inhaler for symptom relief. This should be given for an 8 to 12 week trial. For step 2 though, the management is different. If the child's symptoms do not resolve during the step 1 trial, then we should check inhaler technique and adherence, inquire as to whether there is an environmental source triggering symptoms, and review if an alternative diagnosis is likely. If none of these reasons can explain why the treatment hasn't worked, then we should refer the child to a specialist in asthma care. If, however, the symptoms do resolve during the 8 to 12 week trial with a paediatric low-dose ICS, then we should consider stopping the ICS and SABA treatment and review the symptoms again after a further 3 months. If symptoms reoccur or there is an acute episode which requires systemic corticosteroids or hospitalisation, then we should restart the SABA inhaler and the regular inhaled corticosteroid. For the inhaled corticosteroid, we should begin at a paediatric low dose and titrate up to a paediatric moderate dose if needed. We should then consider a further trial without treatment after reviewing the child within 12 months. If asthma is then uncontrolled, we can consider a leukotriene receptor antagonist in addition to the ICS for a trial of 8 to 12 weeks, stopping it if it's ineffective or side effects develop. If the asthma is still uncontrolled, then we should stop the leukotriene receptor antagonist and refer the child to a specialist in asthma care for further investigation and management. I'll admit that all this is quite a lot to initially get your head around, and I would really recommend looking through the different algorithms within the new guideline that summarise all the different diagnosis and management pathways. Moving on next to monitoring asthma control. As well as asking about time off school or work due to asthma, the amount of reliever inhaler used, and checking if oral corticosteroids or hospital trips have been needed. New in the 2024 guideline is that we should also consider using a symptom questionnaire such as the asthma control test. Another change in the new guideline with regards to monitoring is that peak flow is out and FeNO is in. We are now advised to consider FeNO monitoring for adults with asthma at their regular review and before and after changing their asthma therapy. We are no longer advised to use regular peak expiratory flow monitoring unless there is a person-specific reason for doing so. The guideline also advises that we should consider actively identifying people with asthma who are at risk of poor outcomes. Risk factors should include non-adherence to medications, overuse of SABA inhalers, which would be more than 2 inhalers per year, needing 2 or more courses of oral corticosteroids per year, or having 2 or more visits to an emergency department or any hospital admission for asthma. In primary care, people with asthma should be reviewed at least annually and after any exacerbation by a healthcare professional with appropriate training in asthma management. And finally, the last area that I'd like to cover is self-management. Everyone with a diagnosis of asthma should be offered an asthma self-management programme, comprising of a personalised asthma action plan and education. In adults, this may be based on symptoms or peak flow or both. In children, symptom-based plans are usually preferred. Asthma action plans in English and in a variety of other languages can be freely downloaded from the Asthma and Lung UK website, and I've put links to a few of them in the show notes. Further education should include advice about potential triggers, smoking cessation, when to seek help, and for people aged 17 and over who are using an inhaled corticosteroid in a single inhaler, advice on increasing the dose of their ICS for 7 days if their asthma control deteriorates. Now, as promised, it's time for the quiz. Question 1. You see Alex, a 10-year-old boy with asthma diagnosed 4 years ago with spirometry. He's currently following a paediatric low-dose MART regime and using the inhaler twice a day, but also about 4 times a week to relieve breathlessness and wheezing triggered by sport. What would be your next step? Well, as he's using his inhaler to relieve symptoms on 3 or more days a week, then this indicates that his asthma is uncontrolled. And you should consider reasons for this, such as suboptimal inhaler technique and passive smoking, and consider increasing to a paediatric moderate dose MART. Question 2. You advise him to increase to a paediatric moderate dose MART regime. When should you arrange to see him again? The answer is after 8 to 12 weeks. Question 3. Next, you see Alex's younger sister Lucy. She's 3 years old and her mum is worried that she also has asthma, as she's had a persistent dry cough for 8 weeks, which is worse at night and after running around. She's currently under the paediatricians for a peanut allergy. Would you prescribe her a paediatric low-dose corticosteroid inhaler, a SABA inhaler, or both? The answer is both, to be given for an 8 to 12 week trial. And lastly, question 4. For adults who are using an ICS in a single inhaler, if their asthma control deteriorates, they should be educated to do what with regards to the ICS inhaler? The answer is that they should know that they can increase the dose of their ICS for 7 days. This may be by quadrupling the regular ICS dose, as long as doing so doesn't exceed the maximum licensed daily dose. How did you do? Thank you all so much for listening today. I hope that you found this podcast helpful and that you've learned a few extra nuggets of information. As always, all of the links to the resources I've mentioned will be in the podcast show notes at GPnotebook.com, and we'd be very grateful if you would consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email support@gpnotebook.com if you have any questions, comments or ideas for future podcasts. Right, I'm off to buy a thank you card for NHS Dumfries and Galloway for helping me to work out exactly what inhaler and dose to prescribe for a paediatric low-dose MART regime. Goodbye.